So let's go to the last part of our discussion, which is treatment, therapy for cognitive impairment. We all crave treatments for disabling features like that. Can you just give us a quick rundown about some of the pharmacological treatments being developed by some companies and the non-pharmacological treatments that have been developed by psychologists?
Now, this has been a really important topic. It's been about 20 years right now since people first started saying we need to use pharmacological interventions to treat cognition. So the reference point is, around the mid-1990s or a little bit before, people had clearly come to the conclusion that cognitive impairment is real, it's not being caused by antipsychotic treatment, and we need to focus on it. So there have been a number of efforts targeting these systems, and usually the systems that are targeted are three different things. One is the dopamine system, particularly the dopamine D1 receptors, because it turns out that it's been shown in animals that in the cortex there are more D1 receptors than D2 receptors. D2 receptors in the subcortical regions are probably associated with psychosis, but stimulating D1 in the cortex would be really good. The problem has been that it has been very challenging to develop D1 agents that cross the blood-brain barrier. And that has been our biggest problem. The research in animals involved direct application inside the brain of the D1 receptor. We can't do that. The other intervention strategy has been looking at the cholinergic system, because acetylcholine is the transmitter that is associated with Alzheimer's disease. So concentration, attention, working memory, and episodic memory are dependent on the functions of the acetylcholine receptor. Until just recently, however, it's been very challenging to treat that. There are two general subtypes of acetylcholine receptors. One is muscarinic. That's the one that's implicated in AD. The problem with muscarinic receptors is that in the periphery, if you take a muscarinic agent that activates the system, it causes intense gastrointestinal distress. No one can tolerate it. Recently, a drug has just been developed by a company called Karuna Pharmaceuticals that's taken an old M1 agonist and grafted onto it some properties that don't make you sick. So that's something that's very important. We'll keep an eye on that. The third domain is the glutamatergic system. And the glutamate system interacts with the dopaminergic system. Glutamate is the transmitter that tends to respond when you take drugs like PCP or ketamine. You can create an analog of psychosis with those drugs, but most importantly, it's an analog of psychosis that includes cognitive impairments. So manipulating the glutamatergic receptor system, which is very complicated, has been a target. Because of the complexities of the receptor system, you can't just go give a glutamate agonist. Because first of all, there's two receptors, right? There's glycine and NMDA at some of these receptor sites. So companies like Cadent Pharmaceuticals have developed agents that are modulators. So rather than just trying to slam in and stimulate the receptor or block a downstream target of the receptor, what these modulators do is they try to get the receptor to fire normally, to respond to normal signals and to produce output that's congruent with what you'd want to see in a healthy system. So that could be very, very positive. There are challenges in pharmacological cognitive interventions because you can't stop someone's antipsychotic just because you want to treat their cognition. And so you can't give a drug that makes psychosis worse. And so you can't give a drug very often that interacts with some of the antipsychotics that people have to take.
Excuse me, Phil, but you mentioned the NMDA glutamate receptor as a key target to help improve the cognition, and that Cadent is working on that. Isn't NMDA receptor actually one of the most important theoretical receptors in schizophrenia, with a lot of evidence showing that it is hypoactive? And is this hypoactivity responsible for producing, eventually, through the dopamine system, the delusions, hallucinations, but also responsible for the cognitive impairment?
Yes, and this is what's so important about this particular receptor, because it may provide the linkage between cognitive impairments and psychosis in schizophrenia, and that the downstream regulation of dopamine by the NMDA receptor is impaired. The hypoactivity of the NMDA receptor is associated with excess dopaminergic subcortical activity, which is associated with psychosis. So the trick is you have to manipulate the NMDA receptor in a way that doesn't make psychosis worse while you're treating cognition. And that's why modulation might be a strategy. Other modulatory strategies have been tried, including modulating the other co-receptor at NMDA besides glutamate, which is glycine. And right now, there's a company out there, Boehringer Ingelheim, which is doing a study looking at glycine inhibition combined with a psychosocial intervention to improve cognition in schizophrenia. So there are several exciting developments tapping into receptor systems that had been previously inaccessible because the discovery of these modulators is really new. So this is something that's a very new development. And previously we were stuck in the sort of old primitive idea that it's not that different than Haldol, right? You have to either push a receptor to fire more, or you have to block its target, right? You either have to be an agonist or an antagonist. And now with modulation, this might be totally different. And all these strategies are modulatory.
So eventually, hopefully, if a drug is developed for cognition, one or more drugs, they will have to be given side by side with the antipsychotic. So it's a combination therapy once that day arrives. Let's talk about non-pharmacological approaches like cognitive remediation. Can you tell our viewers, like, what is it that you can do to improve cognition without giving a medication?
Yeah, there's been a lot of research on computerized cognitive training and cognitive remediation in people with schizophrenia. And the success has actually been pretty good. What happens is it's been shown that you can actually improve cognition with training. And the dose is not enormous, and the duration of training is not enormous, and the cost is negligible. So for example, if you look at the most reputable of these systems, Brain HQ from Posit Science, they charge about $10 a month to self-administer their computerized cognitive training. What it is it's exercises that are designed to do just what we talked about before. Essentially, work both at stimulating the frontal lobe to better manage other kinds of cognition, but also to directly work on processing speed and working memory to go from both the top to the bottom in terms of the organization. There have been some studies suggesting that people who are in the prodrome or people at the time of their first episode will self-administer computerized cognitive training with a higher likelihood than that they'll take their antipsychotics. So you get about 80% adherence to self-administered computerized cognitive training and about 40% adherence to antipsychotics. It's now known, though, that you really need to take your antipsychotics at the same time in order to get a benefit from computerized cognitive training. Some fantastic research done out at UCLA has recently shown that long-acting injectable antipsychotic medications combined with computerized cognitive training at the time of the first episode lead to remarkable increases in recovery, threefold improvements. So we're ourselves going to take on a study like that in the immediate future as soon as our COVID crisis dies down. But the computerized cognitive training is very promising. It's important to stick to the reputable groups. There have been some scandals in that area. And we wrote a paper about the path between advertising and science that was published a couple of years ago. It's been quite popular. And so one of the things that's happening is it's really important to realize that for both cognitive enhancing drugs and for computerized cognitive training, that you can improve cognition, but you still need to focus on skills. If I gave you 20 IQ points right now and you'd never played the piano before, you're not going to know how to play the piano just because your intelligence is higher. And taking the train or getting a job is the same. Those are skills. You'll learn those skills a lot faster if you've got better cognitive capacity, but they're not automatically a part of cognition. That's why we talked about the cascade. Cognition underpins functional abilities, which then lead to good outcomes. So we enhance your cognition. We train your functional skills, like in a vocational training program or a social skills training program, and then you get better outcomes. And that's been shown in several studies today.
There's an interesting study that I'm sure you're aware of. One of our colleagues actually gave patients money and it worked. If you reward them with money, they can actually improve their cognitive performance. How does that work?
Well, I think the money is aimed at engagement. So it's not like what will happen is if you get paid for successfully completing a training session, and the payment is based on basically completion and engagement, then you can't help learning as a consequence of that. If I pay you for just going in and coming in for the session, it's been shown that it doesn't work. But we've used studies where we get people to respond to survey questions that they might not want to respond to otherwise by carrying around a smart device. And if you pay them every time they respond to a survey, they'll respond and it doesn't bias their data. So paying people for engaging is a very viable strategy.
Okay. So let's start wrapping this up. Obviously, we covered a lot of ground, and cognition is so important as a key element in schizophrenia, the cognitive impairments that we discussed. So why doesn't DSM include cognitive impairment, a test of cognition, as part of the diagnosis instead of just clinical symptoms?
Well, it's a challenging and sort of politically charged answer. It used to be in DSM-4, the last DSM-4, they used to require a neuropsychological assessment in order to diagnose dementia. They took it out because people weren't doing the assessment and weren't diagnosing dementia. If you put a cognitive impairment requirement into the diagnosis, then insurance companies could refuse to pay for treatment if you couldn't prove that you'd done a neuropsychological assessment. Even at a very high quality medical center like ours, we don't have the resources to do a neuropsych assessment on every one of our acutely admitted patients because we have 28 admissions a day. And there's not enough hours in the day to do 28 neuropsych assessments. So the idea is the current diagnostic criteria, because it's based on disability, right? Criterion B generates a population that has cognitive impairments. And I think I was involved in this discussion at the time of the DSM-5, and people were very concerned that people would be reluctant, or psychiatric facilities might not have the resources to do the assessments. Psychiatrists might not feel comfortable diagnosing cognitive impairment without an assessment, and insurers might use that as an excuse not to pay. So it's a three-pronged answer. But absolutely, cognitive impairment is a core feature of schizophrenia in all its variants, and bipolar disorder as well.
Yeah. I mean, I want to say out loud that I believe that every patient with psychiatric disorder presenting to us for the first time deserves to have a cognitive assessment, because it tells us more about the brain sometimes than an MRI scan. It tells us the functioning of each brain region. So I hope at some point we will have that routinely, even though, like you said, it can be logistically difficult. But there are enough, neuropsychologists who can test our patients whenever we need them in order to have that information in the chart.
Technology is helping. The COVID crisis has created a need to be able to do remote cognitive assessments. Exactly. If you can do remote cognitive assessments on research participants, you can do remote cognitive assessments on people in a psychiatric inpatient unit or in a doctor's office.
How is that working for you? I mean, are you doing a lot of cognitive assessment now with telepsychiatry due to COVID?
Absolutely. We have markedly increased that. Plus, I'm working with some technology people I work with to take other neuropsych tests that are challenging to administer remotely now and make them more accessible. At the end of the day, you might, since it's a remotely accessible test is intrinsically self-administered, you might be able to develop a program where people could be asked to simply spend 20 minutes self-evaluating their cognitive performance on the computer without the need for scheduling an appointment, billing, and all that stuff. And I think that's going to be the wave of the future.
How do you, Phil, how do you handle the paper and pencil part of the cognitive assessment with telepsychiatry?
Well, let's take the example of trail making part A. Okay. Yeah. What we're working on is enabling the camera feature in the tablet to actually observe the patient's finger while they're doing the trail making test on the touch screen of the computer. So that way we would have a check to see if it's actually the patient who is doing the assessment. Similarly, by videoing and and using technology to evaluate the person's performance on practice trials, and to have automated reminders if the person stops performing the test while they're still being timed, we're developing a strategy to do digit symbol coding as well. Memory tests are very simple because we're doing memory tests over a smart device now, where the words are presented on the device screen, and then afterwards the device asks you, was this word part of the list before or not? So there's no human interaction and no auditory presentation. It's all visual, and it doesn't involve typing or writing, it just involves touching, and that's the key.
Technology to the rescue. I'm so glad we are advancing technology for the sake of our patients. Phil, I want to thank you very much for this outstanding tour de force of discussing cognition in general, cognitive impairment in schizophrenia, its description, its measurement, and its potential treatments in the future. Thank you very much, and hope to see you soon at one of the meetings we go to together.
Well, thank you. Thanks for the invitation, Henry.
My pleasure. Take care.